Now, I'm sure many of you are familiar with the so-called red flags. These are clinical indicators that are useful to consider when you're assessing patients with low back pain. Now, the first of these considerations is the patient's age. If somebody is younger than 16 or older than 60 with a new onset of low back pain, then to make an assessment that the patient has non-specific low back pain is still often true, but you do need to consider other possible options, because more serious disease is much commoner in those age groups, and to present with simple back pain is much less common. If the patient describes any weight loss, then that is, as you know, a very significant symptom that merits further investigation. Patient describes, either directly or on direct questioning, any numbness affecting the buttocks or genitalia, particularly if that's associated with a disturbance of bladder or bowel function, then that merits further urgent investigation and management. When you're taking the history, always establish whether there is a past history of either cancer, HIV, or drug abuse, because clearly if those factors are lying in the past, then there may be a more sinister explanation for the patient's back pain. And fever is always an important symptom or sign, and again may point to there being a more serious explanation for the patient's symptoms. Now, you'll also be aware with the so-called yellow flags in assessing patients with back pain. These reflect psychological and psychosocial problems which can influence the way a patient presents and more importantly, influence how they might recover. Anyone can develop acute low back pain. In most people it settles quickly. If it's not settling quickly, then do consider whether there may be psychosocial reasons for the prolongation of symptoms. And these fall into several different categories. Attitudes. You know, is your patient a worrier? Do they believe that there is something seriously wrong with them? Compensation. Is in the background to this presentation a recent accident either at work or a road traffic accident in which the patient is looking for compensation. Sometimes we can be responsible for prolonging a patient's symptoms by using language which causes concern and worry. Some patients come to me saying they've been told that their spine is crumbling, that they have a severe disc prolapse, and the language that we use is often responsible for patients, particularly patients who are anxious in the first place, to have symptoms which don't recover as quickly as we might expect. Clearly, a history of anxiety or depression is always important to elicit, as frequently patients who are anxious and depressed have symptoms. Their somatic symptoms are actually a reflection of the underlying emotional disorder and that don't reflect a physical problem at all. And always think about the patient's family. Are the family overprotective, or are they underprotective, undersupportive? And what about work? Is the patient happy at work? Is the reason that they're not recovering because there are problems at work which are stopping them from returning to work? Well, thank you for listening to this summary of how we might assess patients with spinal problems. We've covered problems in the neck and problems in the lower back, problems with arm pain and leg pain, and also the elderly group of patients with neurogenic claudication. Obviously, it's a very personal approach that I've shown you today. There are other ways of examining the spine and taking a history and making a diagnosis. So everything that I've done today is how I do it. Thank you very much for watching, and I hope this has been useful.